Just letting you guys know that.
Hey everybody, we are back. We're going to do another Ask Us Anything, and this time I have a very special guest, Dr. Bana Kashani, who's going to be joining us. And this is a really, I think, important conversation in particular. It is about the frustrating saga of unexplained secondary infertility, kind of a double whammy. So what we're going to do is give you a little bit of education and insight. She has her own practice in Orange County, California. And there she is. It's so great to see you. Okay, just so everybody knows, we have a very fancy setup going. Dr. Kashani and I both are recording on Zoom while we're talking to you on Insta. So we do this double recording so that we can have a lot of content to share with everybody across our platform. So welcome, Dr. Kashani. I think first,
Thanks for having me.
it would be so great to get started, I think, with first having you share a little bit about your practice, because I think you have a very personal approach and touch that would be really good for everybody to understand.
Absolutely. So I practice in Orange County, California, particularly in Laguna Hills. And I know it's so cliche, it's so silly to say, but I love what I do. I love getting to know my patients. And so my practice approach is really to just do personalized fertility care. You see me on every single visit. You can call me. You can reach me easily via email or our portal and message. I love to really make my couples see exactly what kind of treatment works for them. There is no one-stop shop. You're not going to just be a number, all of those things. So that's what's different about my practice.
I love that. And I think it's helpful too. You're a mom.
Yes.
Right. So you can really connect, I think, on the level of like how it feels to finally achieve the dream of being a parent. And when you're talking about unexplained secondary infertility, also probably such gratitude for getting to be a mom, and then, to have to face challenges after, and in most cases, after people didn't have a problem with primary. So I think that it's so emotionally painful, and we hear so often people are invalidated, when they're going through the experience. Oh, you should be happy that you just have one. We hate hearing that. So let's start with just you defining secondary infertility for us, and kind of a deeper understanding of really how prevalent it actually is.
Yeah, so secondary infertility, unfortunately, is sorry, just one second. So it's a situation where couples have had no trouble getting pregnant with their first. In fact, they're probably surprised that they're having trouble getting pregnant with their second child. And it basically follows similar definitions to other types of infertility. So if you're over 35 and you've been trying for 6 months, that classifies as secondary infertility. And if you've been trying for over a year and you're under 35 and have previously been able to conceive, then that would be secondary infertility.
Got it. And how prevalent is it?
It's pretty common. I don't think we have a perfect estimate of it, just because a lot of people delay coming in, getting diagnosed. They kind of just keep waiting it out. But I would say about 12% of couples may experience secondary infertility. So that's more like 1 in 9, 1 in 10 people. That's a lot.
That's a lot. Can you do us a favor and lower your computer audio, but keep your audio up on Insta?
Yes.
Perfect. Thank you. I just want to make sure we get a good recording. So everybody that is watching, please get your questions ready, because this is going to be an open Q&A here shortly. We just want to give you some background so A, you're not alone. B, this is common, and C, we completely validate, have such utter empathy for anyone who is dealing with secondary infertility. I think just yesterday, in fact, I did get connected to a gal, and she was on birth control for a couple of years after having baby number 1, but she'd been off birth control for a whole year and was having trouble. So I think I see that all the time, and people are really busy, so I think it sometimes delays them getting into the clinic for a workup.
For sure. Or they just keep basically saying, oh, well, it happened before it's bound to happen. Or they're so tied up with their child that they can't even make appointments the way that they try to when they didn't have other commitments as having a child.
Right. Now, I do know that some clinics also don't allow children to come into the clinic, which makes it even harder. Right. So how do you feel about that?
It's a tough one. So definitely post-COVID, right? In the world of our pandemic we're living in, it's really, we don't allow children to come in just because we're trying to minimize exposures for them as well as, for other patients. But Prior to that, it's a testy thing, right? We have so many people, couples that are so sensitive, understandably. And so to think that, you know, you're coming in with a baby or a toddler or anything, it's kind of, it's hard to see. But obviously in extenuating circumstances and you have no childcare or, you know, you have to get in, we completely understand. We have ways of making
Great. Okay, I do love hearing that. I think that that's wonderful. So what are, in addition to some of the common causes of infertility, changes can occur though between kind of baby number one and the attempt, right? So what are some of the causes that you see after?
Yeah, so I mean, I think that first thing that we have to consider is age, right? So obviously, when you're trying to have your second child, you're going to be older, and that varies from people to people. But there's some people that wait several years, and so when you have a woman who had their first child when they're 35 and then they're not trying until they're 37 or 38, well, their fertility in general is decreased. So I think age, not only for the female, but also for the male, has a significant impact. And then during that duration of time, so many things can change. Couples can develop medical problems. You can develop a thyroid issue. You can develop diabetes. I mean, there's all these slew of different things that can come up. Additionally, lifestyle factors can play a role. So there may be some weight gain that happened postpartum that now is causing some issues. There just might be moments where you're so busy and you're so stressed, you're not taking care of yourself. And so that has an impact. Significant stress, lack of sleep, all of those things can affect your ability to ovulate, and those contribute significantly. And then there's other things, like maybe a woman had a C-section and that caused scarring of either the uterus or the fallopian tubes, or over time periods have changed. And so, you know, the uterus has changed and there's a fibroid now, which wasn't there before, or polyps or overgrowths of tissue in the uterus. All these things can come up. Couples who have children may have an issue where
Oh, that's okay. It happens. Technology is imperfect. Yes, but it's much quieter. Sure. Oh my gosh, that is such a good point about timed intercourse, because that can be such a problem. That timing, in fact, when people were traveling a lot for work, I remember hearing from a couple that they had to do IVF just because they couldn't get their timing right. Yes. Hmm. We do have a couple of questions coming in, so I do want to bounce back and forth between our question set and their question set. And Make Up by Gabby, we're helping her feel not alone. I'm so glad. I mean, it's why we do this. You know, we just want to normalize the conversation, make everybody know that they're not alone, and that we have all these amazing resources and providers to help. So Natalie McGowan has premature ovarian failure, and so she wants to understand her chances of getting pregnant naturally without going the IUI or IVF route. Right. I don't know why I can't hear you all of a sudden. So I think we're not hearing you through Instagram. I'm not sure. Can everybody give us feedback and see if you can hear Dr. Kashani through Instagram? That's my concern. I want to make sure that they're still picking you up because I can hear you through my computer, but not through Insta for some reason. Yeah, they're saying they can't hear you. Do you have any, do you have an AirPod you can put in or an earpiece you can put in for Instagram? Okay, so here's what we'll do, everybody. I am going to I'm going to turn on my computer, and as you ask questions, I'm going to give you Dr. Kashani's answers, and we'll kind of take it from there. So what she was saying about the woman who is dealing with premature ovarian failure, first of all, that is really difficult to deal with, and we know that, and we know that that it's a whole body thing, because if you are dealing with premature ovarian failure, you know, you have reduction of hormones, right, that your bones need for health as well. And she was mentioning that even with timed intercourse, you still have a 5% chance of conceiving, and probably having a good workup, you know, make sure that there's nothing else going on would be warranted. The other question is Makeup by Gabby has Dr. Kashani, does thyroid affect the male's ability to conceive as well as the female ability to conceive? So if a male is having a thyroid issue.
Yeah, so thyroid abnormalities, when they're not controlled, it definitely has a downstream effect as well on male fertility. All of these male hormones come from the pituitary gland, and so they can have downstream effects on sperm development. If the thyroid is well controlled, then we at least can assume that things are going to be functioning fine in terms of sperm development.
Okay, great. I turned my audio up on that answer on the computer to see if you guys could hear it. So could you hear that? Give me some feedback to see if that actually is kind of saving your ability to hear her beautiful voice. Let me know before I keep moving on to other questions.
I wonder, can I leave and come back or no?
You probably can. Yeah. Yeah, so go ahead, try that. I think so, yeah. And I'll keep chatting with everybody while you do that. All right, she'll be right back, everybody. You know, technology is so imperfect, and I love how supportive you guys are. Okay, thanks, Crystal, for that feedback. At least we know that that's a good backup, that I can turn her back up on my computer and you can hear through there. I appreciate the feedback so much. Start putting your questions in, though, and we'll make sure she gets to them. A couple of the other things that, you know, if no reproductive conditions are at play, she kind of gave us some speaker notes in advance and said, you know, celiac disease, poor nutritional intake, you know, poor absorption, certainly unreported recreational drug use. I think that's probably an area that people don't always feel comfortable divulging to their provider, is if they are using pot on a regular basis. We are always talking, Dr. Chen on Monday Motivations and Dr. Raquel on Fertility Tip Tuesday. We're always talking about how you can't smoke weed when you're trying to conceive. It's just such a killer. And it just really is. So, you know, that's definitely a big area to consider, and that's men and women. Steroid use definitely is a big one for men, or if they're taking testosterone, that's also a big one. Okay, here she's going to, we're going to add, sending the request. And then when should you keep trying again after a miscarriage? That's such a great question. There she is.
So sorry about that.
I can hear you. This is great. Okay, good.
Overcame it.
Okay, I'm so glad. We're all used to technology on the fly, and
okay.
you know, that's perfect. Okay, we just got a great question that came in. When should Adele Martinez keep trying again after a miscarriage?
Yeah, so that's a great question. Previously, the thought was you have to wait some time, right? But if you are mentally ready to be able to start trying, there's no reason to delay. There's been good studies out there that says actually trying right away, 1 to 2 months after miscarriage, can be associated with pretty good chances of conceiving and continuing on, hopefully, with a good live birth after that. So I never tell people to wait.
That fantastic, and I love that very much. Do you often recommend that they do a water sonogram to just clean out the uterus beforehand?
Yeah.
Is there anything like that?
For sure. So depending on what the circumstances are, and if there's any concern that there was retained product, you know, tissue from the pregnancy, or there was a procedure done like a DNC where the pregnancy tissue had to be removed, then it is a good idea just to make sure there's no residual scar tissue. But you could do that in the same cycle you're trying. So there's, again, no reason to delay.
Okay, well, that's exciting. Hopefully that makes you feel a little bit better, Adele. And we have a lot of conversation around miscarriage and emotional well-being. So we always advocate that that kind of what Dr. Kashani said, that if you're mentally and emotionally prepared and ready, and if you'd like some extra support along the way, we certainly have so many resources for you, and a lot of content around that conversation. I myself had five losses before I had my son. You know, I'm so lucky that I had fertility preservation done, because every time the loss happened, I at least knew in the back of my mind that I had frozen embryos. So it did help me cope with the losses, because I had, you know, something to turn to. Not everyone is in that position. And so I know myself, the devastation, especially the first one. The first one rocked me for a full month. I mean, just a full month. I was in a very, very deep depression. And I think, you know, the embryos kind of, you know, brought me forward, you know, to be able to kind of try again and take the next step. And then, you know, I ended the relationship in which those losses had occurred and had my son on my own. So he was a day 2 frozen embryo, you guys, for 5 years. 5 full years. And he just ran in as a 7-year-old and gave me his iPad. So he's grown up in this business. So he knows how important it is to help other people. And I always say to him, like, it's so we can help other people have their Dantes.
Yes. Aww.
So yeah. Okay. Hi from Glendale, MERS, XOXO. I love that handle. That's a fabulous handle. And you're welcome, Adele. Yes, we're happy to answer more questions too. One of them that we were prepped for is, can secondary unexplained infertility be caused by a combination of factors in both partners? And kind of who do you look at first? You know, if somebody needs to go through those diagnostic steps. And while you were gone, we did cover your advice about some of the other sections. So
yeah, so unfortunately, infertility can be affecting both couples, male and female. So you never ever want to assume it's one or the other. I would say at least a third of the time, it's actually a combination of both the male and female factors. So I never ever go in a particular order and say, let's just start with the female first. I think both the male and female should get everything checked at the same time, because if there are things like, you know, slightly abnormal semen parameters, we can help with lifestyle modifications. You can take supplements, you can improve things. So why wait on assessing something like that? So, and same thing, likewise for a female.
Well, I love that. And let's be real. I mean, there's so many at-home collection kits for male sperm. Get that part knocked out of the way, right? Sure. Like in the comfort of your own home, get a baseline semen analysis. And at least know that, you know, look, I mean, I'll endlessly be jealous about how efficient the male body is compared to ours. But and every 3.5-month washout is just not fair. Yes. But it gives you such hope if male factor is part of the equation at all. We had somebody yesterday that had been in conversation with us this week on the lives, and her husband's motility was low. Okay. And so that was part of the recommendation, was like, hey, just know that there's all kinds of things that he can do and improve. Sure. And then 3.5 months, you'll see if his hard work paid off, right? So there's and makeup by Gabby. She's already been trying to conceive for a second child for 1 year. So at that point, you know, she's really ready to come in and see a specialist, right?
Absolutely. I mean, it's hard coming in. We know that it's hard fitting it in, and you keep hoping maybe this month will be it. I don't totally. Right? But it doesn't fault you to at least get the evaluation started, at least get the information that's needed, and even some tips on what you can do to naturally optimize your fertility. So I really, really ask that everyone watching, listening, don't hold back. Come in, talk to a specialist. We want to help. And, you know, hopefully by the time you come back for your follow-up visit, you're already pregnant. But don't postpone and delay, because again, time is of the essence, and postponing is just going to make it harder in the future. So.
And our audience knows I'm the biggest advocate of speed of getting into a specialist. You know, I say this all the time. We have this really bizarre area of fertility where people kind of over rely on generalists, on their OBGYNs, and the OBGYNs want to do the best that they can. But you have such specialty training in looking for things that the OBGYNs don't have the training for. Sure. So we don't want people to endlessly take Clomid. We don't want them to endlessly try. We just want them to get in as quickly as possible because of that time decline. Absolutely. Like Absolutely. Every passing month, there's a decline in our fertility.
Yep, exactly. That's exactly the case. And I mean, you know, a lot of times people don't think with secondary infertility the problem's as serious. So they're like, okay, no big deal. I don't have to jump to a fertility specialist. I'll just do some of these basic tests and get started. And again, that's fine. It all depends on your access to being able to get in with a provider. So OB is a great resource to start with, but
Sure.
again, please don't, you know, hesitate on getting some sort of additional treatment or getting some answers to your questions.
I mean, that's the biggest thing, right? Is just the answers. Let's just get the answers to the questions so that they know if treatment might be in their future. And I remind everybody all the time that the great IVF doctors out there, they're called REIs, but they're not there to sell anybody IVF, right? So you're not there to sell a treatment. You're there to first do your inspector job and figure out what's going on, doing a full diagnostic, and then working with the patient on the best course forward.
Exactly.
So we have Yes Blue asking, what are the chances of conceiving under, I'm not familiar with this particular medication, cabergoline? I was prescribed cabergoline due to high prolactin. She's now at normal range, but no luck yet.
Okay, so cabergoline is a medication that can help decrease prolactin levels. In general, women shouldn't have a high prolactin level unless they're lactating. It helps produce and so when you have a high prolactin level, it can interfere with ovulation. So if that was the case and you're not ovulating and you're not getting your period and you start taking cabergoline or another medication, bromocriptine, then it can help you ovulate and it should hopefully help you conceive earlier. However, it doesn't always help. Like if you were having regular cycles, but your prolactin was just high, taking this cabergoline doesn't necessarily, you know, double your chances of getting pregnant. It does normalize things. It's definitely good to be on it, but it depends on the reason why you were started on it too.
Okay, that's interesting. So if perhaps maybe an ovulation confirmation each month to see if it's really doing its job. Yes, if her prolactin levels are lower, but if she's still not ovulating, she needs to figure out if she's still ovulating or not, correct?
Correct.
And you can then, so she could do that with a scan. I don't know if you're familiar with some of the newer tests on the market at home, like Prove or Uva Life. Yeah, exactly. So those might be good options. We do work with Uva Life. One of our other virtual partners does work with Prove and Uva Life both. But yeah, those would at least let you know if you have ovulation confirmation, not the LH surge window, but actual proof that you've released an egg, and that's the most important. So maybe as a good very low cost next step, she could at least learn that piece of data.
Those options. Absolutely.
Okay, we have Allison writing in, getting prepared for her second FET. The first ended in miscarriage. Wow. We're heartbroken to hear that, and we actually, this is a perfect segue because we have to talk more about miscarriage as part of secondary infertility anyway. She did do genetic testing on all the embryos, and all the genetic testing on her embryos, they have come back normal. So what are the chances of live birth with a second transfer?
This is really hard because obviously, you know, we put so much weight in the embryo. And so to not have an embryo take, it is crushing. It's really crushing. You start questioning all these things about yourself and what, you know, the embryo was normal. The embryo was normal. Why didn't this happen? And that's really tough. So, you know, the chances of having a second transfer work, a live birth, are pretty high. Okay. In general, an embryo should have about a 60 to 70% chance of resulting in a pregnancy and live birth. But there's some measures that should be taken before your second transfer, just to ensure that you optimize and increase those odds. So I always have an updated hormonal evaluation done for my patients. I also make sure we triple check the uterus and make sure there's nothing in there that could have caused that transfer to the embryo to not take or implant. Even some things like a chronic lingering infection called chronic endometritis can have an effect. And then you have to go back and look at the protocol. Maybe there was something off with the timing, right? So an embryo has to be put in during this finite window of implantation. And if that is off a little bit, even a perfectly normal embryo put in may not take. So there is a test out there called the endometrial receptivity assay that you can explore with your doctor to see if that is a good option for you. And that may help to just fine tune the timing for your transfer and will increase your success. So those are the things you want to consider before going right into a second transfer. And hopefully it will work.
And some of the things that are so frustrating about miscarriages after PGT normal embryos is the expectation, of course, that everything is chromosomally normal.
Yeah.
But the reality is we don't have all the information. We only have a little bit of information about the embryo. And certainly as those cells are dividing and multiplying and growing and hopefully growing into a fetus and then hopefully ending in a live birth,
Right.
there's a lot of changes that are happening genetically along the way.
Yes.
So I think that's a really hard part of it. It's our best foot forward. And you certainly don't want to put an abnormal embryo in that we already know has a trisomy or some other reason that's going to cause a miscarriage. So I think those are the most frustrating sometimes when we hear that it's like, oh, we know you put your best foot forward. And I love your approach though of like, well, let's look at every other possible thing. And the harsh reality, of course, being that 2/3 of cycles fail the first time, and that success, though, the cumulative success of staying in the game, of doing another cycle, of doing even up to that third cycle, right? I mean, some of the women that I know who come on our episodes and they're like, I'm on my 7th cycle, and I go, geez, the fortitude, it's heroic. It's absolutely heroic staying in the game.
That people keep going, because I think that that's one of the biggest reasons why people fall out of treatment and give up, which they shouldn't. They really shouldn't. There is definite information out there that if you can continue, it will result in a live birth. But it is so hard and crushing when it doesn't happen.
Yeah. Oh, it's so hard. And look, everybody out there who's heard me talk about my story before, this is a 13-year journey. I'm taking a full 7 years in between my children. I'm gearing up for a second embryo transfer, and I'm taking truly a full 7 years in between. And I'm still not looking forward to the progesterone injection.
No. Not at all.
I needed that break. But fortunately, the embryos are so young. All right, excellent. So Frenchie Jen is asking, how long does the trigger shot stay in your system before you can do a test?
Yeah, that's a great question. It depends on which trigger shot that was done. Some trigger shots have higher doses of HCG, some have less. And it also depends on, every woman is a little bit different in how they process it and excrete it in their urine. In general, I would assume it's going to stay in your system for 7 days. But in some women, it can stay as long as up to 12 days. So I don't want people to do this necessarily because it could drive you a little crazy, but there are people out there who will use some of these cheaper pregnancy tests and test out the trigger, just test it every day until it fades and goes away. So then if you do see that true positive, you know that it's real, but that's not for everyone, right? So you have to decide what works for you, but I would give it a minimum of 7 to 10 days.
Okay, that makes sense. So people just are metabolizing things at different rates. It's sort of like with caffeine and alcohol, same thing. You can be a fast metabolizer or slow metabolizer.
Weight and all these other factors as well.
Okay, got it. That's super helpful too. So let's talk about then all those treatment options. We sort of have danced around them, but let's do a nice little summary of what are the treatment options for somebody who is going through secondary infertility.
Yeah, so it comes down to, some of the reasons why you're infertile, but you can do things as simple as ovulation induction. If you stopped ovulating, you can take pills, hormones, or injections to help you ovulate. There's treatments such as intrauterine insemination, or IUI, where you can help get the sperm to their destination, the fallopian tubes, faster. You kind of bypass them having to swim that long journey. So that's IUI, and you can combine that with pills or hormones to get you to ovulate more than one egg. Those are pills like Clomid or Letrozole, or injections of hormones. So that's kind of one option. The other alternative is obviously IVF, or in vitro fertilization, where we're taking egg and sperm, combining them in the lab and creating embryos that can then undergo genetic testing and can then be transferred into the uterus. In certain circumstances, there are situations where, you find out, again, you may have ovarian failure and there is no opportunity to conceive with your own eggs. So there's great options of using donor eggs, donor embryos, and doing an embryo transfer through that route. You can alternatively switch to trying to use donor sperm if needed, if something came up significant with your partner. So those options are available too. And then there are cases, unfortunately, where somebody no longer can carry a pregnancy. Something came up with their first delivery that damaged the uterus, or after a miscarriage caused significant scarring. And so there's options of gestational surrogacy or using a gestational carrier to be able to help carry your pregnancy. You would have to do IVF, create those embryos, but then somebody else can carry them for you. So those are all very broad options. Everything should be, specific to you and your partner and what works best for you. But it's important to consider having those discussions with a doctor.
Yes, I love that. So before we wrap up, we can certainly take more questions from everyone. I saw, I think we covered the few that came in. And I think that, one of the things to remember is that there are the sort of low tech and then high tech methods that Dr. Kashani just described.
Yeah.
And we never want the idea that you need an expensive treatment or the most expensive treatment to prevent you from getting in for a full workup.
Absolutely.
We advocate for this over and over and over and over and over again because people wait too long. The average patient, even in our Fertility Answers app platform, has already been struggling for 3 years before they have gone in for a consult. It's too long. It's too long.
Yeah, it's way too long.
It is. It's just way too long. So, we really want you to get in as soon as possible, and we're here to help financially. Okay, so I'd rather know now how I need to help you in 6 months or 12 months, right? So that you have all your options in front of you. And what we never want is that a time delay is the difference between using your own egg or not using your own egg. I have lots of friends.
Point. I'm so glad
Yeah. So do you see that a lot in your practice where it's like, gosh, just 6 months ago, we would have seen a different outcome?
Yeah, I mean, it's incredible once you get to those situations or circumstances where there is advanced ovarian aging, that 6 months, a year makes a huge, huge impact, especially over the age of 40. So please keep that in mind. I mean, time is really of the essence. So there are programs available. There are financial programs. There's loans. There's all these things that can be done. And so please don't let that dissuade you from trying. I mean, it is a daunting consideration to think that you have to pay out of pocket thousands of dollars if you don't have insurance to cover things, but I promise you it does make a difference to get treated earlier than later.
Yeah, exactly. Okay, I love that. Well, that's all we have for everybody today. So why don't we wrap this up? But I think I'd love to hear just your thoughts as we do, like your parting wisdom on self-care during this time, because certainly as we kind of open the conversation, that this pertains to a patient population that is already a busy mom and dealing with the stress and trauma of having secondary infertility. So what are some of your best self-care recommendations that you can end us with?
Yes, so I think that's great. I think that first off, if you can connect with a partner that will, be part of this journey with you and open up, because a lot of people, too many people, keep things inside and they feel uncomfortable because, they were able to get pregnant before, or friends around them are on their second child and no one understands. They tell them, just be grateful for what you have, which is not the right way.
No, it's not.
So search for a support group or find somebody you can confide in. And again, maybe that's your partner, maybe it's a support group, maybe it's, a long lost friend who you think had gone through something similar. That's obviously very helpful, but please take time for yourself. That you have a busy schedule, you have a child at home, you've got, all these other obligations. Even 10 minutes in the evening where you can just do a little bit of fertility meditation, just focus on yourself, something like a hot shower that you usually don't get to take for more than 5 minutes. All of these things can be helpful. There are apps out there that can help you with self-guided meditation, particularly with those with infertility. All of these things are, very beneficial for you. And then pay attention to what you're doing in your lifestyle, pay attention to your diet and trying to incorporate more healthy foods, such as, more whole foods, fruits, vegetables, things with antioxidants. All of these things are going to be helpful for both you and your partner. So those are things you can do on the side as well.
Absolutely. And certainly the health foods that it was very difficult to eat first trimester of pregnancy. So think back to how difficult it was.
You want to have those all on board prior.
Yes. All on board prior. You got to load up on them, because first trimester, if you were anything like me and my friends, it was hard to force down some of the actual good for you foods. I just carved it up and ate a lot of oranges. I craved oranges in my first pregnancy. Yeah. So CL Mayfield, I'm not sure if you're referring to me or Dr. Kashani, who's got beautiful new hair. I don't know. Is it mine or is it yours? What was your hair like before? But we haven't seen her in a while, so good to see you. Savannah's just saying hi, and @TNB5 saying hi. And you're welcome. Yes, Blue. I love that. One of the things I used to do with my first child, and still sometimes, if he lets me, which is rare, is do Epsom salt baths together.
Oh,
so
cool.
Yeah, because when they're really little in particular, oh, thanks, Jill Mayfield. She said me, thanks. This is my version of like not having time to do my hair today.
That's great.
I love you so much. And it's just the Epsom salts are so good for, for both mom and child.
For
It's
sure.
really relaxing. It's really calming. I would add some like lavender oils in there, and then the nights that I did that with my son in particular, when he was really little, I mean, he just slept so great.
That's amazing. Yeah.
Yeah.
So
Acupuncture
acupuncture is
nice
also
thing.
nice self-care to consider too. So it has a lot of
Yes.
benefits. And I love that it's just an hour of your life where you can just go in there, take some time for yourself, which we, again, don't get if you're, already have children, you're a busy mom. So
I love that you're advocating for that, because sometimes we talk about on the show mixed data on acupuncture, and we're huge advocates of it, in particular because the relaxation impact is so profound.
exactly.
And, are you, with your practice, do you have, people that you refer out to that are really close by that, you've got like a
We
little
have people
network?
we refer out to right around us. And then,
Cool.
we're pretty open to, we have some people who come here. So I love having acupuncturists come before and after transfer.
Great.
And so I think anything you can do. And again, it's all about that self-care. Acupuncture is self-care. It's time for yourself that we don't get in this crazy world of ours. So I definitely recommend acupuncture.
And a lot of insurance companies will cover at least a visit per month, especially if you have pain, and other things like that, where the data is very strong about the benefits. So that's something that might even be covered by insurance, which is amazing. Allison is coming back on, considering transferring 2 embryos with her second transfer. This is a really good, important question. She wants to know, will it increase her chances of live birth if they do 2?
Yeah. So, in general, the American Society of Reproductive Medicine, all of us fertility doctors will advocate getting pregnant with 1 embryo and having 1 single pregnancy. But there are cases and circumstances where you can transfer 2, especially if you haven't done genetic testing on those embryos and you're of older age. Then we know that it can definitely help increase the live birth rate, because we assume that maybe one of those embryos may not be normal and may not take. Okay. So that's a discussion and consideration you should have with your doctor. In general, though, if you've done genetic testing and you're putting in 2 normal embryos, really it doesn't increase live births that much significantly. What it does increase significantly is the risk of twins, and twins are going to increase your chances of having a pregnancy with complications. So
Right. I remember spending most of my pregnancy being afraid of twins because I did put in 2. And back then it was kind of, it was 13 years ago when I made the embryos, and the science changed so much between the time I made the embryos and did my first transfer, that it was sort of presented like, well, you have a really high success rate if you put in 2. And now the story is totally different. So I literally, even when I had my C-section, Dr. Kashani, I was like, they brought out Dante. I got to meet him, and I said, "Are you sure there's not another one in there?"
You were so worried.
I was so worried for that long. Like, I can't be a single mom of 2 at a time. Yeah. So this is still a controversial conversation, because I think that a lot of patients get on the Facebook groups and they get on chats with each other and they say, "I'm going for twins." And
That's
because
true.
they're paying for it out of pocket, they feel like a 2 for 1.
Yeah, everyone.
And it's just really not the case. And we can't stress enough the risks to mom and both babies, by approaching it that way, and why why ASRM and so many clinics are trying to move standard of care. But it takes a lot of advocacy with the patients to get the education out there in the right way for people to really understand that sometimes, even if your benefit might, you might look at a benefit and go, oh, it's like a 15% increase in success rate, but it's also an 85% increase in risks. And like, we don't want that when you have like the cumulative success rate of just 1 at a time is what we're really looking at, and why the unfortunate thing is we have to counsel people head into IVF knowing that you probably need more than 1 round. We want you to be one of the lucky few that needs only 1, but knowing that at least 1 egg retrieval, maybe back-to-back FETs, is more realistic.
Sure. That's great.
Yeah. So let's see. Let's just wrap up with CL Mayfield. I haven't seen you in a while, so it's good to see her. She's mentioned before, so she's got a lot going on. She does have PCOS and stage 4 endo. She has 2 miracle children, a 7.5-year-old and a 4-year-old. And she started tracking her ovulation 4 months ago. So she's had regular LH charges, but she has PCOS, so she should be tracking with something that's not LH, right?
Right.
So let's start there. She has some more sort of inputs, but let's start there. PCOS and LH, can you just very quickly talk about why that is the wrong tracker?
There's many hormonal changes that take place in women who have PCOS. One of the things that we do see is that some women have a high baseline level of the hormone LH, or luteinizing hormone. And unfortunately, in those women, it can be very tricky to try to track ovulation, because what you're trying to detect is a rise in LH. So you may check at the beginning of your cycle, knowing you're nowhere close to being ready for ovulation, and see a positive kit and get so confused because you're like, wait, why would I be ovulating now? Right. So in those cases, it doesn't work for those women. So we have to use other measures to try to track ovulation. And this is something that you can, again, do on your own. There are ways that you can track your cervical mucus to see if there's changes with that can indicate possible ovulation, or tracking your body temperature. Again, these aren't perfect measures for everyone, but there are some sophisticated things out there that can help track body temperature now. So those are things you can consider. You can track after you've ovulated with some tests that check urine levels of progesterone. But if that's too hard, you can also go ahead and try to see a doctor and see if you can track ovulation just through ultrasound monitoring or blood work. That would be more specific and helpful.
Okay, that's great. So let's go to part 2 of her of the feedback loop for CL Mayfield. So the same month that she actually saw the surgeon, she actually wasn't having any period. So she definitely knows she's not pregnant, went to the OBGYN to confirm it's not pregnancy. She's, even with everything that has been going on for her, she's never missed a period before. So she used to have very heavy periods. Years before the endo would have welcomed it. Probably not having a period to give her body a break from probably heavy periods if she had low iron. But now that she's tracking and trying, what are some of the things that you would be looking at, since she's never missed one before, in terms of like a full workup? What are some of the things that she should be looking at
for determining
why all of a sudden she's not having a period, and which probably means that she's not ovulating?
Yeah, absolutely. So, I mean, if there's been changes in weight, that can be an explanation on its own, but I would get things updated, like maybe getting your thyroid checked. The other hormone is prolactin, just reassessing some of the female hormones. Maybe there's been a change in your ovarian reserve or egg number, and that's impacting things. So checking FSH, LH, estradiol at specific time points throughout the cycle. Those are all things that should be done to figure out if that, could be contributing to a lack of ovulation.
Right. And just remember, you can have an LH surge and no release of an egg.
Right.
So that's why we're advocating that you get in to confirm if the actual releasing of the egg happened. I know Dante's a great timekeeper, and he's always checking in on me when I'm on these lives to make sure that I wrap it up on time.
I love it. He's got to come on one of these lives one day too.
Sometimes he will pop in, but other times he's unless he's actually gaming and recording a gaming video for his own YouTube channel, he doesn't like to show his face. So yes, CL Mayfield. Oh, okay. Yes, exactly. So Prove is a kit you could use at home. Uva Life is a great kit you can use at home. But I think even better is going into the doctor and just getting scanned in that phase of what should be your cycle after those LH chart changes, or heightened LHs, to see if look at the follicles, so you can see if you've ovulated or not. But I'm so grateful to you, Dr. Kashani. I know we have technical difficulties. Don't even sweat it. I mean, it's IG, everybody's used to it. This happens, and we just roll with it. This is the era of live TV while everybody's at home still.
I know.
So that's okay, but we'll have you come on again. You did a fabulous job, and we're just so grateful for it.
Me. And feel free to message me if anyone has any questions or anything at all. I also answer questions on fertility. Answers, always here to help.
And you answer so beautifully. I just want to thank you for that. You're full of empathy, and you're doing a great job. I do want everybody to know what your handle is so they can follow you. So where can they find you on Instagram?
Sure. Sure. My Instagram is at dr period Bana Kashani, BANAKASHANI.
And her last name is so fun to say, Kashani. It just rolls off of the tongue. I love it. Well, thank you so much for all you do for us in our community. And
good
we'll
luck
see you
to
soon.
everyone trying. Fingers crossed.
Yes, exactly. And don't forget, you can always connect with a second opinion and consult with her via telemedicine.
Yes.
And we welcome that opportunity as well. You can request a consult right through the app. If you're not in the app yet, Fertility Answers on both iOS and Android, we're here for you. We love you. And we just want everybody to have your happy dream come true. And we'll see you next time.
Take care, Alice.
Okay,
Bye.
thanks. So, bye.